Good morning. Uh, my name is Dr. Rajesh Donepudi. Today I am giving a presentation as a part of my neurology rotation in epilepsy. I will be focusing on epilepsy treatment and the challenges in the usual challenges in the treatment of epilepsy. I'll be presenting in the order of epidemiology, defining epilepsy, uh, types of epilepsy, the pathology of epilepsy, physiology, treatment, and the treatment resistant epilepsy. First, epidemiology. Epilepsy is a common disease. Nearly 1.2% of the US population has epilepsy, and every year 44 new cases are reported for every 100,000 individuals. And the incidence varies from developed and developing countries, indicating that the causes of epilepsy uh, strongly depends on uh, social factors. So epilepsy is a very old disease. It's been there for hundreds of years. Hippocrates called it sacred disease. Hippocrates was the one of the first people who actually thought it is a brain problem that caused epilepsy, but it is seen in as a different thing in different civilizations. Some people thought people who have seizures are possessed, whereas some people thought uh, the people having seizures were blessed. But epilepsy fascinated everyone from scholars to normal people equally. Coming to definition of seizure, it is a clinical manifestation of an abnormal and excessive excitation and synchronization of a population of cortical neurons. And epilepsy is a tendency toward recurrent seizures unprovoked by any systemic or acute neurologic insults. And epileptogenesis is sequence of events that converts a normal neuronal network into a hyperexcitable network. And next, coming to classification. Epilepsy is mostly broadly classified depending on the symptoms exhibited by the patient. Here we see the international classification. It says focal seizures, generalized seizures, or unknown. In focal seizures, the origin of seizure is considered to be on in one hemisphere of cerebral cortex, whereas in generalized seizures, the origin of seizure is maybe in one hemisphere, but it spreads to the other hemisphere also. And in focal seizures, the characteristic idea is they have this aura. They can sense when they are going to have a seizure. And sometimes focal seizures can also evolve into bilateral convulsive seizures. And generalized seizures are again classified into many types: tonic, clonic, absence, clonic, tonic, atonic, depending on the type of movements they exhibit during the seizure episode. Tonic, clonic being the most common type. Absence and myoclonic seizures are the more prevalent in the childhood, whereas complex partial seizures are more common in older populations. So, nearly 20% of the people who are diagnosed with seizure actually don't have seizure. They have non-epileptic seizures, whereas the most common form of seizure is focal seizure, which is nearly 60% of seizures, and the next common is generalized seizure, which is 30% of seizure. Coming to focal seizure demonstrate focal lesion on EEG uh, and, and show a specific origin of foci. Focal seizure with sensory or motor features most often arises in the sensory motor cortex, whereas focal seizures with impairment of consciousness most often have the foci in the limbic and autonomic areas or in the temporal lobe. As I already told, focal seizures have this aura where the patients can sense they are going to have the seizure anytime soon. And most of the aura, most of the uh, patterns are olfactory hallucinations, somatosensory, gustatory hallucinations, and these hallucinations and these extra symptoms also help us localize the foci of origin of seizure in focal seizures. For example, for if the patient has olfactory hallucination, it is most probably the uncus where the origin of foci is. And for gustatory hallucination, it is mostly the temporal lobe where the origin of foci is. Focal onset in the temporal lobe, or that may be a hallucination or perceptual illusion, period of altered behavior and incomplete impairment and unconsciousness, a discognitive state, deja vu, a feeling of intense perception of familiarity in an unfamiliar circumstance or place. Jamais whose strangeness or unfamiliarity or strangeness in a previously known place. Temporal lobe seizures are the most common form of focal seizures, and they exhibit these particular pattern of symptoms, deja vu, jamais who. And coming to generalized seizures, most of the times generalized seizures strikes without any warning. Unlike the focal seizures where the patient can sense when they are going to have a seizure, generalized seizures don't have any such warning signals. They begin with sudden loss of consciousness. Most of the times, patient falls to the ground, causing severe injuries. Initial motor signs, typically a brief flexion of the trunk, opening of mouth and lids, and upward deviation of eyes. Arms are elevated, abducted, elbows semi-flexed, hands are pronated. And generalized seizures, they have a particular pattern of movement of the muscles, tonic clonic, atonic, myotonic, like that. Tonic clonic being the most common type. In tonic clonic generalized seizures, there are two clear distinct phases where in the first phase, more protracted extension is seen involving back, neck, arms, and legs, and then there is a piercing cry caused by biting of the tongue, biting lateral margins of tongue, causing uh, air to get stuck in the vocal cords, and it causes a sound similar to piercing cry, followed by a clonic phase where it is similar to generalized tremor, which is followed by violent flexor spasms. Coming to pathology of epilepsy, when they try to study the biopsies or the specimens from the dead people who had autopsies, they couldn't find any significant lesions in the brain. So epilepsy can arise from grossly and microscopically normal brains, as seen in seizures from drug intoxication or electrolyte abnormalities or metabolic abnormalities. But many epilepsies have gross abnormalities in CNS like tumors, degenerative changes like medial temporal sclerosis. So, what causes seizures? For long period of time, it is thought that there is some anatomic basis in a particular part of brain. Some chemical change may cause seizure, but after that, with the advent of EEG, the total understanding of epilepsy changed. They were able to understand that uh, it is the electrical phenomena that is causing these seizures. Hans Berger invented the human electroencephalogram, which allowed him to confirm that convulsions were the result of abnormal electrical activity in the brain. Major contribution to current understanding comes from extensive works of Henry Jean Pascal Gustave using EEG. Causes of recurrent seizures. In adulthood, in elderly population, the most common causes of recurrent seizures are tumor, vascular disease, degenerative disease, whereas in younger populations, the common cause of recurrent seizures are uh, congenital causes, but physiology of epilepsy. Physiologically, epilepsy requires three conditions: a population of pathologically excitable neurons, an increase in excitatory glutaminergic activity through recurrent connections in order to spread the discharge, a reduction in activity of the normal inhibitory GABAergic projections. So abnormal neurons, increase in excitatory neurotransmitter, or decrease in inhibitory neurotransmitter. These are the three prerequisites for seizures to happen. There is also a role of genetics where channelopathies are linked to some gene-based inheritances, which also actually cause seizures through the above mentioned three conditions. Diagnosis. The ideal way of diagnosing seizure is EEG and clinical evaluation. In clinical evaluation, getting history from the patient is more important. And there are long-term EEG monitoring methods. And there are video EEG. And for some causes like a tumor, we can do imaging like CT, MRI being the most uh, dependable thing. And we can do laboratory testing, serum lactic acid being the most commonly raised newer tests. There are some newer tests which are getting more popular in diagnosing seizures, like serum prolactin, serum ACTH, and serum cortisol. Several studies show that serum prolactin is increased 10 to 20 minutes after seizure in all types of seizures. And elevation, uh, evidence of elevated prolactin helps in differentiating seizure from pseudo seizures. But the thing with these new tests is we need to have a knowledge of normal baseline to use them for diagnosis of seizures. So approach towards a new patient. Nearly 20% of the diagnoses which are made as seizures, epilepsy, are actually not epilepsy. They are epilepsy mimics. So we need to make sure when a patient comes to us with a seizure, with a complaint that they had a seizure episode, we need to really make sure that is it really a seizure. For that, we need to take a clear history. It is important to get a detailed account of the episode. We need to ask what happened, where it happened, talk to a family member, whoever is accompanying the person when it happened, type and duration of the movements. We need to get information about type and duration of the movements, level of alertness and responsiveness, skin color, breathing, has any incontinence occurred. Talking to person who witnessed the episode tells more than some of the tests. Uh, if none of the person is available and we prefer to do tests, it is better to talk to the person or call them, do some random tests. Treatment. The main treatment modalities available for epilepsy are anti-epileptic drugs, surgical treatment, and other methods like vagal nerve stimulation, ketogenic diet. The mainstay when a patient is diagnosed with epilepsy, the mainstay of treatment is anti-epileptic drugs. And when they fail, surgical treatment is uh, preferred, anti-epileptic drugs. The concept behind anti-epileptic drugs is uh, most of the drugs work with so mechanism of action of most of the anti-epileptic drugs boils down to uh, either decreasing the excitatory uh, neurotransmitter or increasing the inhibitory neurotransmitter. It is a dynamic target of seizure control in management of epilepsy is achieving balance between factors that influence excitatory postsynaptic potential and those that influence inhibitory postsynaptic potential. First-line treatment anti-epileptic drugs, carbamazepine, effective against focal seizures and generalized tonic-clonic seizures, valproic acid, effective against a broad range of seizures but may have teratogenic effects, lamotrigine, effective against focal and generalized seizures, particularly absence seizures, phenytoin, particularly used for focal seizures and status epilepticus. Second-line seizures, used when first-line options are ineffective or not tolerated. Levetiracetam, broad-spectrum AED, used for various seizure types. Topiramate, effective against focal and generalized seizures, also used for migraine prophylaxis. Oxcarbazepine, similar to carbamazepine, effective against focal seizures. Zonisamide, effective against focal and generalized seizures, also used for migraine prophylaxis. Newer anti-epileptic drugs. Lacosamide, effective against focal seizures, also used for diabetic neuropathic pain. Rufinamide, used for treatment of Lennox-Gastaut syndrome, a severe form of childhood epilepsy. Parapanel, effective against focal and generalized seizures, works by blocking glutamate receptors. So the first use of anti-epileptic drugs in the history is potassium bromide. It is the only thing available until 1912. In 1912, phenobarbital was first used. Right now, there are nearly some 20-25 FDA-approved drugs currently in use. So there are a limited number of drugs which mostly have similar mechanisms of action. Teratogenic effects of AEDs. All conventional drugs are well tolerated in pregnancy. However, potential teratogenicity is the main issue. Valproate has the most teratogenic potential. Reduction in verbal IQ in children born of mothers exposed to valproate during pregnancy. Most common teratogenic effects are cleft lip, cleft palate, and facial dysmorphism. Fetal anticonvulsion syndrome, similar to fetal alcoholism. Uh, Surgical treatment for epilepsy. Excision of epileptic foci not responding to medical therapy. Nearly 25% of all epilepsy patients are actually candidates for surgical therapy. Isolating foci is a challenge when surgical treatment is considered, but focal epilepsy, especially with temporal lobe involvement, are ideal candidates for surgery. 50 to 90% improvement in seizure is noted, especially focal temporal seizures. Vagal nerve stimulation is helpful in pharmacoresistant patients when more than two adequate trials of anti-epileptic drugs have failed. Vagal nerve stimulation can be tried. Vagal nerve stimulation works with a pacemaker-like device which is implanted in the anterior chest wall. and a wire which stimulating electrodes are connected to the vagus at left carotid bifurcation. Even the mechanism is unclear. Average of 25% reduction in seizure frequency in patients who are resistant to pharmacotherapy is noticed. Brain responsive neurostimulation and deep brain stimulation are more invasive things than vagal nerve stimulation. Ketogenic diet. Many trials demonstrated a reduction in seizures in half of the patients with severe and interactable episodes. Ketosis is induced by following a diet in which 40 to 50% of calories are derived from fat. The diet is not so palatable, which leads to abandonment by nearly one-third of patients. This Most of the trials of ketogenic diet are on the children. Nephrolithiasis is the most important complication. The thing with ketogenic diet is benefits persist even after the diet has been stopped. Coming to drug-resistant epilepsy, when a patient seizures are not getting under control, even after adequate trial of two anti-epileptic drugs, it is called drug-resistant epilepsy. It is also called refractory epilepsy, intractable epilepsy, uncontrolled epilepsy, or pharmacoresistant epilepsy. As seen in this diagram, nearly 50% of patients with epilepsy, the seizures get under control uh, with trial of first anti-epileptic drug. In the remaining 50%, 13% of patients get their seizures under control with the introduction of second drug, and 4% get their seizures under control with the third drug, and 33% of patients uh, still have seizures despite of using multiple anti-epileptic drugs. So, what causes drug-resistant epilepsy? It may be due to wrong diagnosis. As we already said, nearly 20% of epilepsy diagnosis are misdiagnosis. So, when we say drug-resistant epilepsy, it may not be epilepsy at all. The other thing may be the treatment is wrong. Maybe the ideal drug is not being used, or the compliance, the patient is not taking the drug correctly, regularly. There may be inadequate control of triggers, severe sleep deprivation, alcohol consumption, limitability of anti-epileptic drugs. Sometimes, despite everything, seizures just do not respond. So, when we say the diagnosis may be wrong, um, it is a wrong diagnosis. Most of the times, the actual diagnosis could be the mimics of epilepsy, which could be any of this. It could be fainting, syncope, or hypoglycemia, low blood sugar, migraine with confusion, sleep disorders such as narcolepsy, movement disorders, tics, tremors, dystonia, panic attacks, psychogenic events. Psychogenic non-epileptic seizures. It is the most common misdiagnosis of epilepsy, and 70% of people diagnosed with psychogenic non-epileptic seizures have been previously diagnosed and treated for epilepsy. Three broad categories for psychogenic states seem to generate pseudoseizures: panic disorder, dissociative disorder, malingering. The social impacts of pharmacoresistance. When the seizures are not getting under control, despite using multiple anti-epileptic drugs, the patients still continue to have seizures. It totally upsets the patient's life. impacts drastically. They have social isolation. They have to be dependent on someone. Such people have low rates of marriage, unemployment, they have comorbidities, psychological issues, reduced quality of life, and economic burden on society. So, what is the reason for development of this pharmacoresistance? Currently, there are two hypotheses which are believed to cause drug-resistant epilepsy. First one is target hypothesis. Alterations in pharmacological targets of anti-epileptic drugs in brains of pharmacoresistant patients lead to failure of anti-epileptic drugs to block excessive excitatory potentials. Second thing is transporter hypothesis. Excessive expression of these transporters may be excessive expression of these multi-drug transporters may be removing the drugs from the epileptic brain regions. Despite the huge funding and development of new AEDs, nearly 30% of patients are still pharmacoresistant. Currently, there is no drug that can actually prevent epileptogenesis. Many times, patients need to be on multiple drugs to reach proper seizure control. As we already saw in the picture, nearly 50% of patients only achieve seizure-free, get control of the seizures with one drug. Then they need to add one more drug to get seizure control, one more drug to get seizure control. What happens is they will be using multiple drugs at that time, and they will have adverse drug reactions, polypharmacy. So there is a need to understand the mechanism of pharmacoresistance, and there is also need to development of new anti-epileptic epilepsy drugs.
Okay.